Good morning, everyone. I'm Guido Filler. I'm a professor of pediatrics medicine and laboratory medicine at the University of Western Ontario. Next. I would like to share with you a study that we were able to do before the use of physiologic solutions with the particular question, what is more important for growth in pediatric peritoneal dialysis patients? This may in fact be one of the largest single-center studies that was ever performed. Next. I have no financial relationships to disclose relevant to my presentation. Next. So I'm hoping that at the end of this session, you will be able to understand the common problem of growth retardation in children and adolescents on dialysis, understand that more urea clearance once a certain threshold has been reached does not affect growth, and appreciate the impact of full correction of metabolic acidosis, and learn about measurement of intraperitoneal pressure. With the physiologic solution, the bicarbonate is often slightly overcorrected, but with the conventional solution, the patients very often have a profound metabolic acidosis. Next. So let me start with an introduction. Next. So while in many countries we now have physiologic PD solutions, there are actually really large countries like the United States that do not have physiologic solution. In a collaboration with a single center in Curitiba in Brazil, we were able to study this in a prospective protocol that was retrospective analyzed. And growth failure is very common in pediatric patients, and it is unclear if the prescription of high PD doses can improve the growth velocity. Next. So we conducted a study of 53 children on PD who underwent adequacy testing every 9 months. We actually hypothesized, similar to very important studies in adults like the CANUSA and the ADEMEX studies, that growth velocity, which is considered a good surrogate for the cardiovascular morbidity or mortality, would not improve once a certain threshold of KTV or KT over V is reached. In that center, they were actually very aggressive about the 3D prescription, and as you will see, we often exceeded the guidelines. Next. So in the next section, I'll talk about the patients and the methods. Next. So we identified 73 patients in a single tertiary center that was basically a tertiary university hospital responsible for the entire state of Paraná. And patients who were treated with peritoneal dialysis after 1997 and who underwent adequacy testing between June of 2000 and 2005 were considered. We had some exclusion criteria, most importantly uninterrupted dialysis, no transplantation, and having repeated testing. And we were left with 53 patients that met the inclusion criteria. Next. So the mean time between the testing was 210 plus minus 75 days. We did ask the research ethics board of the university, and because it was a pure retrospective study of a prospectively applied protocol with testing every 9 months, and because it would not change the management of the patients who had undergone the treatment, it was considered exempt from research ethics approval. Also, consent was not required. Next. So, as I already mentioned, inclusion criteria were at least 2 consecutive adequacy tests every 9 months apart, no interruption between the tests, and no patient, importantly, received human growth hormone therapy, which of course is an approved therapy for improving the growth failure in chronic kidney disease, However, I would like to point out that the state of Paraná does not reimburse for recombinant growth hormone therapy. Next. Next. So we did the standard adequacy testing with the 4-hour protocol. It was using an equilibration test with a target valve volume of 1,000 milliliters per meter squared. And where applicable, the first equilibration test was performed at least 1 month after catheter insertion because we gradually built up the pre-prescription. The phosphate binder that was used in the study was calcium carbonate. We used laboratory values as was in the protocol, and unfortunately did not include hemoglobin, which is creatinine with the modified Jaffe method, urea, calcium phosphate, intact PDH, and weekly KT/V urea. We also measured the intraperitoneal pressure as per Fischbach. Michael Fischbach published a landmark paper in Kidney International in 2016. Next. So the treatment was with standard non-physiologic solutions. The significant number were on CCPD, as I will show you. We captured the catheter flux and complications. We used standard anthropometry using certified stereometers and scales. In the younger children, it was done supine. In the older stage patients, it was done standing, which is the gold standard. Nutrition was optimized by dietitians in every patient. 6 patients were tube fed via gastrostomy, and the statistical analysis was done using GraphPad for Windows or Mac and SPSS. Next. So for those who attended the previous talk, we know that we can assess the membrane type, and studies from Latin America suggest that about 50% of the patients are actually high or high average transporters. Next. So what were our results? Next. So the patients were on average about 8.6 years old. They were about 113.8 centimeters. The height Z score was minus 2.29, so they already had a very substantial catch-down growth at the initiation of the peritoneal dialysis testing. The weight was on average 18.85 kilograms, and the BMI was 15.35 kilograms per meter squared, so they were partially very thin. Minimum was 11.53. The dwell volume was about 37.5 milliliter per kilo. The total dialysis volume was about 4.9 liters per meter squared per day, which is actually quite a high. The average intraperitoneal pressure was 11.4 centimeters water per meter squared, and the drain catheter flow was about 379 milliliter per minute per meter squared. The average potassium was 4.2, so they were well dialyzed. With that in mind, the intact PTH was high at 199. One patient had a suppressed PTH, but all others had actually slightly or significantly elevated values. The serum albumin was 35.7, so there were not too many patients that were nephrotic. We know that low albumin is bad for the growth. The weekly KT/V urea was 3.13 and went up later, and the weekly PD or KT/V urea was 2.31. The total creatinine clearance was 59.3 liters per week and 1.73 liters square. Next slide, please. So the mean age at the initiation of the dialysis was 8.7 years. 42% had obstructive uropathy, 30% had acquired glomerulopathy. There was also a significant proportion of hereditary nephritis in 21%. We also did include 4 patients with infantile cystinosis, and we know that they have particular problems with growth failure because of the Fanconi syndrome. In 6% it was unknown, and 1 patient had vasculopathy. And at the first testing, 30 patients were on CAPD, 10 on CCPD, and there were also other methods involved. And by the time of the second testing, 3 patients were converted from CAPD to CCPD, 2 patients from CAPD to NIPD, and 2 patients from NIPD to CCPD. And at the time of the second testing, the patients were 9.2 years, plus minus 5.3 years old. Next slide, please. The mean fill volume was very close to what was required, 969 milliliters as a median. and the second test was 961, so there was no change. The median total infused volume was 5.26 milliliter per meter square per day. As you can see, some patients received very high doses for normalized to body surface area of 15.32 liters, which is actually significantly higher than at the first visit. That was due to the protocol that was trying to push the dialysis as much as possible. The median residual urinary output was 411 milliliter per meter squared, and the second visit it was slightly lower at 377, but it did not reach statistical significance. And the median total weekly KTOV was 3.79, which was significantly higher than the 3.13 at the first test. Next. So the creatinine clearance increased from 59 to 72 liters per week and 1.73 liters squared. And the median intracranial pressure normalized to body surface area was 10.89, but there was a wide range. The catheter flux was 349 milliliter per minute meter squared, and 49% of the patients were high transporter on the second PET. Next. So the first interesting thing, but it does confirm the literature, is that there was a relationship between the intraperitoneal pressure and the fill volume. So the thin patients have a lower intraperitoneal pressure, which leads to less wetting of the peritoneal membrane and should have influenced the growth. Next. When we just compared the intraperitoneal pressure versus low and high body mass index, then we just used basically the cutoff of the middle, then there was a significant difference in the intraperitoneal pressure, with the high body mass index having a lower intraperitoneal pressure when you just take the absolute values. Next. We then tried to find out which parameters actually did affect the growth. And nutrition is a very important thing, and we unfortunately did not assess for compliance of prescribed nutrition. But when people had a positive increase in the body mass index, then they grew better. Versus the ones that actually had a catch down growth, then they grew worse. Next. So what else influenced growth? Well, we correlated everything, and 53 patients is a very good number for a pediatric study. Next. And as you can see, on average, we actually lost and had a catch down growth of another minus 0.12 standard deviations. This is unfortunate because they already started with an unfavorable growth and were already well below 2 standard deviations at the initiation of dialysis. Next. So while this may seem as if there might be a trend and maybe with more patients, but more weekly KTOV urea did not significantly affect the growth. Right? You may think at the first glance that there could be an effect, but it was definitely not significant, and the R square was only 0.096. Next. So delta height, that score did not correlate with any of the dialysis parameters. The median delta height SDS in the anuric group was minus 0.1, and was also not significantly different from the delta height SDS in the patient with residual urine output, whereas this patient would have had more clearance, and they should have had better growth. And adenotic bone disease, we know, is a well-known complication that will affect the growth, and basically there's no treatment for it except that you can try to overcome it with growth hormone. But only one patient actually had a suppressed PTH, and he may have had adenotic bone disease, but all others actually had elevated PTH value. And using univariate analysis, height velocity correlated significantly only with bicarbonate. Next. So when we then controlled for age, which of course, the growth velocity is very age dependent, And the most important factor, there was only a weak but non-significant trend with the velocity and bicarbonate. But after we adjusted for age, total, and PD, KT or urea, we still failed to show any relationship with the dialysis prescription. And using multivariate analysis controlling for age, tendency was found between bicarbonate, infused volume, and between the Schwartz eGFR and infused volume. Similar relationships between the dwell volume, the Schwartz GFR, and the intraperitoneal pressure. Of course, higher GFR would indeed favor better growth. Next. We then analyzed what parameters differed between those patients who were above and below the Z-score, and the average height velocity of minus 1.7 in the high transporter group was not significantly different from the other patients, although the literature would suggest that the higher the transporter type, the worse the growth velocity. Also, they tend to have lower albumin. But we did find a trend towards a better delta height SDS in patients who were not high transporters, if we looked at it from a one-sided fashion. Next slide. Remember, 49% were high transporters. And really, after doing all sorts of calculations, we only found significant differences for bicarbonate concentration. And the median bicarbonate concentration was 23.1 in the group with poor growth, compared with the group with good growth, that was where it was 26.1, and that was highly significant. Next. So what does this mean? Next. So this single center study with a large pediatric cohort, perhaps the largest single center study that was ever published, evaluated the feasibility of KT/V urea as a dialysis prescription target for growth in PD patients. The median weekly KT/V was quite high at 3.79 and exceeded the guidelines. And unfortunately, aggressive PD prescription did not alter growth velocity. Age had a strong effect on growth as expected, and growth was only otherwise dependent on bicarbonate concentration. Children with a positive growth velocity had a high normal or even elevated bicarbonate concentration. Next. So, of course, there are a number of limitations. It's a single center study. The retrospective study design is always a limitation. The assessment of residual renal function with a 24-hour urine is very error-prone in the pediatric age group. And there was no formal assessment of nutrition adherence. And also there was, unfortunately, with the paper charts, some inconsistent medication documentation. But for a single pediatric study, a large number of patients, it actually does draw some important conclusions. And very similar to the ADEMEX and CANUSA study, we were able to study a significant range of dialysis prescription, and it does not improve the growth. So once a certain threshold, when that's published in the guidelines, is reached, then exceeding that will not necessarily help. It may help with ultrafiltration, but it will not help with the growth. And the study really highlights the importance of overcorrecting the acidosis, which is often not corrected with non-physiologic PD solutions. With the use of physiologic PD solutions, you always see like a bicarbonate of 26, 27 millimoles per liter. Next. So what can we conclude from this study? Next. So similar to the CANUSA and ADEMEX studies, once a certain threshold of PD prescription is reached, excessive KT/V urea prescription do not improve the growth. But what we can learn from the study the most is that for those of you who do not have access to the physiologic solution, that it really highlights the importance of a full or maybe even aggressive normalization of the bicarbonate to improve the height Z-score. Next. I would really like to acknowledge that this study would not have been possible without the collaboration with my friends in Curitiba and Chapel Hill. My co-authors are Lucy Mary de Castro Silvestre. She is in Curitiba. Brigiana Paula Bernardis, who was also in Curitiba and the leader of Nephro Kids, and Deborah Stremel Ribeiro Curitiba, who was then the nurse who collected all the data and everything. She now works for public health in the city of Curitiba. And my dear friend Maria Esther Diaz Gonzalez de Ferris, who is at the University of Carolina at Chapel Hill, who helped me to analyze the data and write the manuscript. Thank you for your collaboration, my dear colleagues. Next slide, please. So, with all the limitations of a retrospective study, I hope that I have shown you that excessive PD prescriptions do not improve the growth. However, improving or even just monitoring very carefully what the bicarbonate of the patients is may be a good tool to improve the growth of these patients. Thank you for your attention. I'm happy to take any questions.